Welcome, Matt. Thanks for joining us here on this virtual Global Day of Action with our Support Don't Punish. Thanks for coming. Actually, quite excited about your session. This is an area in which we have seen some reform in light of the COVID restrictions through more accessibility of OST in particular, delivery by courier to people who use drugs, who are, very much tied up with the housing crisis in Dublin City, for example. We're here down in Cork, but there are different problems up in Dublin than there are here, and that's very much like a housing crisis, which is quite national at this point. But we had heard from a previous session there with Anna Quigley from Citywide. Access has been basically like what we've kind of learned from the past. We've already known this. This isn't anything new, but I guess it's given us a sense of urgency given the crisis, and we learn now that the criminal law is not as important as public health. Public health right now at the moment is very, very important. We see more access through delivery. That's something that we'd love to keep on going in the future. But it seems you guys in the UK have been doing something for a while now through your P2P Naloxone model. Could you describe this for us through this session? I look forward to it, and we'll have a bit of time for a Q&A at the end as well, I hope.
Yeah, look, I'm really happy to come and talk about this project we've been developing together. And what I'm going to be showing you is a presentation that we actually, or a part of a presentation we made to Public Health England, their national intelligence meeting, where we were pitching to them this idea, because the UK has been through a bit of a lost period in terms of harm reduction for the last 15 years. Now, the British model was renowned for its pragmatism, and Liverpool was really seen as the home of harm reduction in many ways, pioneering needle and syringe program. And then we've gone off from Tony Blair pushing towards more criminalisation, and then towards more like service user types model, through to now this full-on recovery model, really, which has been a very politicised model. I'm not sure how far governments actually believe in it, bar a few ideologues, but it gives them the excuse to localise the drug management of drugs, and also to, in doing so, massively cut the drug sector along with the wider austerity programme in the UK. So really, things had been really bad, and for many drug user groups, we were working in our communities, carrying on doing work. Some of us were working internationally and in Europe, but really, I think we were really frustrated with what had happened in the UK, and attempts to network had been really sabotaged by the government, both deliberately and unintentionally. So the big changing factor was the Glasgow HIV outbreak in 2015, where the arrival of cocaine in the city there among the homeless population, the downgrade, the fact that harm reduction services had been run down, as was happening across the whole of the UK. It created the conditions where we had an HIV outbreak like 30 years after our first HIV outbreak, an absolute disgrace for a country that has prided itself on being one of the pioneers of harm reduction. So that was a really big wake-up call to the UK. And one of my first speeches back in the UK was to really wag a finger at the government and say, what have you done? This is not surprising. Why have we got so many drug-related deaths? No, this is a consequence of bad drug policy. But then we turned around and said, look, we're not going to just carry on bitching about it. We want to come forward with pragmatic solutions. So we came forward with drug user groups and said, look, we haven't gone away. We've stopped working with you as a government because you closed down the space by having this ideologically driven recovery model. But we've been back working in our communities, promoting naloxone, promoting peer-led harm reduction, whether we were paid to do it or not. And also we were networking with our European and international peers, developing knowledge, developing learning. So while the UK was in the wilderness, we carried on pushing forward with peer-led harm reduction. So moving on to the second slide in my presentation, this is one of the forms of peer-led harm reduction that we wanted to promote, was this concept called peer-to-peer naloxone, or P2PN. And peer-to-peer naloxone was part of a strategy developed by EuroINPUD, the European Network of People Who Use Drugs. And we had two parts to our strategy, and we modelled the project in the UK, but not necessarily to say the UK was the only place this work should be done, but really to highlight that the UK was a place where we could deliver the work and then create toolkits that could be applied in other parts of Europe. So the first part was a naloxone access and advocacy project, which was based on auditing the existing model, which was called take-home naloxone. So this was using professionals and other stakeholders to get naloxone out into the community. However, they tended to be connected with the treatment populations. So it meant that you were getting naloxone to the 50% of problem drug users who were in treatment, but not necessarily doing so well at getting naloxone to the population most at risk, those who were not in treatment. So firstly, we audited take-home naloxone and identified some of the flaws in the program and suggested constructive ways in which the systems could strengthen that part of the response, because we're not calling for take-home naloxone to end, we're calling it for it to be augmented. So what we're calling for it to be augmented with is what's called peer-to-peer naloxone. And this is where drug users are involved in distributing naloxone to each other, normally doing a small, brief 10-minute intervention, training people in the basics, equipping people with a naloxone kit like this, Pranoxad, or the nasal version Nixoid, or even the really low-tech version, just a simple, very cheap amp. They all work. 0.4 milligrams of naloxone is a life-saving drug that can give the brain a chance to keep the lungs functioning and going until enough opiates have passed out of the system to allow the person to live. So that's a very powerful tool. But if we don't get enough of the naloxone out into the drug using community, particularly among active drug users, then we're not going to be successful. To understand why peer-to-peer naloxone is so significant, in Glasgow, a group of drug users in 11 months gave out 1,300 units of naloxone. Now that was more, and that was in one district of Glasgow. That was more naloxone than every single healthcare professional gave out across the whole of Glasgow in the preceding year. Now, once people started to see this being replicated across the country, people were quickly sold on this highly cost-effective model of distributing naloxone. Now, some of this peer work can be done through drug user groups, others can be done as peer programs, others can be done as volunteer programs. It can be done in different ways, and there's different ways of coming at it, but the key principle is drug users doing the program for themselves. And as the third slide highlights the strengths of peer-to-peer naloxone, it's really highlighting that peer-to-peer naloxone is significant because we as drug users have access, what's called privileged access to drug using venues, to drug supply systems. We can operate in the very systems that are designed to keep other people out. We have the ability to flow through those systems as trusted players. And in fact, the closed nature of those systems almost becomes an asset to us, where we can move through drug using venues, drug using scenes, peers' homes, and turn those into places where we can deliver brief interventions and equip people with naloxone. Let me just talk about the legal environment, about why we're able to do this work. So in 2015, under the Medicines Act, the UK government changed the law. And the law they identified was basically to say that in the past, you'd needed to write a prescription to a named person in order to give out naloxone. What happened with the Medicines Act was it allowed a much broader range of people, including drug services and people working for drug services. And that was critical for those of us in drug user groups, because our state is as volunteers for drug services, and that allows us to then take naloxone out into the community. So the early pioneers of take-home naloxone, like Mick Webb in Swindon, they had special arrangements with doctors where they were stretching the boundaries of what was really allowed to do this before 2015. But since 2015, the law has been with us to allow us, if we're working under the auspices of drug services, we can give out naloxone to people in the drug scene. Now, they are currently consulting on the next stage of the legal development, and we're arguing that drug user groups in themselves should be allowed to give out naloxone, subject to being recognised or operating to accepted protocols or being part of an agreed network. So Jen, just to maybe just in the final two slides is just to highlight the pilot work in my hometown of Bath. We've been running a pilot in Bath, which was working with our local provider, the Drugs and Developing Health and Independence, DHI. So DHI were working with us to allow some local suppliers and local peers who allow people to meet up in their homes. It was allowing those people to run needle and syringe programs equipped by DHI, but operating in the drug scene. Now, initially, we've been talking about this. We had a stock out in a local pharmacy over a weekend, which led to lots of reusing and risky behavior. So we accelerated this program. Off the back of it, we were also doing peer-to-peer naloxone. In fact, we only had 20 units of naloxone to play with to start with, but by strategically putting them in the right places in the community, we saved 4 lives in the first 3 months of the program. And this followed a period where 2 people had died in the preceding month. So 2 people died. Then we introduced not full-scale peer-to-peer naloxone, but very strategically placed naloxone in the community. That saved 4 lives in 3 months. And now we've been able to scale up, particularly. And as a response to COVID, we've now become the main needle and syringe provider in Bath, I think it's fair to say, and we're giving out 1,500 units of needles and syringes through local drug users and drug suppliers in Bath. At the same time, we're making sure that naloxone exists out there, and we're now also starting to advocate around the development of a crack pipe distribution scheme as another part of the response to COVID-19. So the final stage is just to maybe tell you about this project that we're developing in the UK. We've got some funding from Public Health England, and we're going to be documenting the work we've done in Bath. And then we're going to be running a webinar to teach people how to apply the learning from the work that we've done in Bath, and then create some small grants to help other drug user groups apply the learning so that we can push out this model of secondary needle and syringe programs and peer-to-peer naloxone and peer-led education, so that we get the UK back to its old tradition of having a really robust harm reduction system, but one that really embraces community mobilisation, so that we come back out of the wilderness after this period of 15 years. So ironically, and as one of our posters for Support Don't Punish Day shows, we're now saying it's time for a new normal, and these features should now become part of the new world order, and we shouldn't flip back to the bad old ways after COVID.
Thanks very much, Matt. That is fascinating stuff. Like, you really are pioneering not just the UK, but the rest of the world. You know, we really are looking on in awe, and it's very inspiring, you know, to see you know, like you creating this new normal and taking this opportunity from COVID, which is clearly a disadvantage for people, but using it to your advantage and showing that actually, you know, through all of this, you know, we actually, does give us a sense of urgency. And of course, the advantages of P2P, like peer-to-peer, is its sense of decentralization. You don't have to rely on one single hub. I love the way in which you can actually get grants and then issue those grants from Public Health England and then downwards in a kind of, you know, you guys as the users, as people who use drugs as a network, are the guys dealing with this. You're the guys running this show. That's like quite different from our experience here in Ireland. Like, we don't really have people who use drugs in any position of power. It's very much a feeling of disempowerment. It's a feeling of fear. It's a feeling of not engaging with services. And the most at-risk individuals are generally not in the system. They're very much at the fringes of it. And until, I think, maybe education needs to change as a first and foremost. Yeah. I mean, could you describe, like, how do you even begin? How do you even begin to start approaching these guys, you know, your government, your local government, and just say, you know, this is the situation. It's obviously pragmatic. How, you know, do you just make contact with them? How did you start?
So I think, well, firstly, I'd like just to maybe explain a little bit about how this Public Health England funding came to us, because Release, which is the very renowned legal drugs charity in the UK, we had been working as EuroINPUD with Release to basically document the changing drug trends in the UK, and that was feeding into meetings with the police, meetings with the All Parliamentary Group on All Parliamentary Group on AIDS, through to the Treasury. So there was this global process going on, and through our partnerships with professional stakeholders, we were able to network into that. And of course, what we bring to the table is my ability to be able to talk to my peers and get my peers coming onto Zoom teleconferences where we had like 20 drug users from 20 different parts of the UK sitting down and describing what was going on. That intelligence becomes very useful when you can deploy it. So that's part of the story. And then Public Health England offered the 5,000 to release to recognise them for this coordination role that they'd played, and to release his credibility, credit and honour. They offered the money to us and said that they thought that we could use it more as a completely unfunded venture, and that they saw that money being highly useful. We'd put in 3 bids in the recent period which had been unsuccessful because they didn't quite fit, and there was a risk that we could lose momentum, and really stepped up as a professional partner and said, no, please give the money to them. And Public Health, to their credit, agreed, so that we're now party to this journey. So maybe to talk about the bigger stories, it's important to recognise that I was a drugs professional, and a reasonably senior drugs professional, for 10 years before I came out publicly as a drug user. So I'm an NHS manager by background. I was running a £1.8 million drug service with 7 drug teams. Now, one of my drug teams was the team I set up myself, called the Healthy Options team, or the team I set up with the team there and the local drug using community, because HOT was the first team in the UK to employ people on methadone, to employ active drug users, openly working alongside other NHS professionals. Now, we were a standout team that did pioneering work. Now, while the parallel teams to HOT in other countries have gone on to be celebrated and validated, after the HIV epidemic, HOT was absolutely destroyed root and branch by hostile forces within the British establishment. And for me, that was one of the reasons I came out publicly at that time and said, came out publicly and decided to tell people that apart from being a very senior drugs professional, I was also a drug user. And these groups that I'd been known for facilitating and supporting, I was actually a member of them. Now, I thought that was going to be more obvious to people than apparently it was. And I remember telling my chief executive, and I'm saying, I'm sure you won't be surprised. And as her jaw hit the floor, I thought, okay, that was a much bigger surprise than I thought. And that's partly because people don't expect drug users to be functional, committed human beings. So to actually realise that the professional head of service and general manager of the £1.8 million drug service was actually also a drug user. The fact that all my staff wasn't a problem, but somehow I was seen as the safety valve. And if I wasn't there, that somehow that was much more risky. So that led to me being sacked after I came out publicly. And I was also dismissed from my consulting company with the probation service, because the probation service said they couldn't have a criminal training their staff. So I, on one level, lost very heavily by coming out publicly. But on the other hand, I had this engagement with the establishment. I'd been working at a government level. I've been on government delegations to the Commission on Narcotic Drugs. So I have privilege. I have privileged access, not just into the drug using community, but also into the establishment and into the professional system. And so I see, one of the things I saw when I came out was that it was drug users often struggled to get their voices heard in the right places. It wasn't that they weren't articulate and they weren't able to, or we weren't able to make voices heard. I've seen drug users from Russia, from Afghanistan, from all over the world make mind-changing, attitude-changing interventions. And I think one of the functions I play is to help drug users get into the spaces where they can have those points of influence.
That's one of the things I actually liked most of your slide, was that final part where it says shared lived experience. That's one of the things that's missing in most of the policies that have made around drug use in probably all of our societies. Yeah. They don't take into consideration the drug users that are going to be affected mostly by these drug policies.
Yeah, look, I was invited. For a long time, I was seen as an expert on community mobilisation, and I was invited to all the conferences for the NHS to talk about the wonders of involving communities. Until one day, I was asked to speak about the new NICE guidelines and National Institute for Clinical Excellence on meaningful involvement. And I made sure that quite a few drug users were invited to the meeting, and then I actually just critiqued the UK's response to drug policy and said this nice guidelines, absolutely fantastic. Now, these set out how communities and patients should be involved, but you don't do any of it when it comes to people who use drugs. And I just went through and highlighted. I've never got asked to speak at one of these conferences ever again, but it was absolutely clear that something happens when it becomes people who use drugs, that all the norms disappear. Who possibly would make policy about a population without talking to that population?
Yeah.
And then best you talk to people who decided not to be in that population or had no. So the only people you do talk to are people who maybe are 20 years in recovery, talking about something that is so out of date that actually it doesn't have real relevance. And that's why even as an older drug user, I see my function is often to help other drug users get into the places where they can make their voices heard. Because my experience as a middle-class affluent drug user is not the same as drug users living under the bridges in Afghanistan. It's not the same as drug users living homeless on the streets in Bath. No, those are the voices that people really need to be listening to in this dialogue.
Very good. Would you be able to, from a practical perspective, describe the distribution hubs or the hubs run by the community for the community in relation to needle exchange and naloxone and any other education-related, drug-related thing?
Yeah, I mean, they'll vary depending. I mean, like, because I also, apart from the work I do in the UK and Europe, I also work in international development. So I've seen this work taking place I've been in drug selling environments in Myanmar, in Kachin, which was a field, and there were cows walking through the river, and there was a tented area set up where a drug supplier was selling heroin to the local farmers, and then he had one guy who was giving out needles and syringes that the local harm reduction providers gave him, and that was being distributed. In my hometown in Bath, it's a local supplier's house, and it's his front room, and he's allowing people to come into his house where he's selling drugs, but he's selling drugs at a level to survive himself. It's not about, he's not a drugs baron. He's a drug dependent person who's managing his use. And then part of his sell is to also have needles and syringes there for people. It used to be there was never enough. They were always scrabbling. Now they have enough a kit for a week ahead. They have 4 different types of barrels, 7 different types of needles, all the other types of injecting paraphernalia. That then creates a space where we can talk to people about naloxone, where we can do crack pipes. These are the places and these are the guys where they save the lives that I talked to you about. So in fact, let me tell you one story of one of the guys there. One of the guys who runs these houses, he taught someone how to use this stuff, Prenoxad, which is a pre-filled syringe of naloxone. He taught someone how to use it. He then had an injection, overdosed, and then the guy he just taught to use naloxone saved his life.
Wow, all in the same sitting.
In the same fight, within about a 10-minute process. And this is a key thing about naloxone. I can be as expert as I like in naloxone. If I'm the one who's overdosing, my expertise in naloxone is bloody useless if I haven't taught it to other people. So the actual nature of peer work is that we have an investment. Even if we were completely selfish, which we're not as human beings, we're just like other human beings, drug users are collaborative and supportive and caring. But even if that wasn't what drove us, the logic of peer work is that actually we logically want to teach our friends because they're the ones who will save our lives.
Not very Hobbesian of you to believe that people are all evil, but rather people are actually all good, and we do tend to live side by side quite well when it comes to self-regulating ourselves. So that's an excellent scenario in which you've built up there. You have a hub which can supply and also be a distribution for the overdose antidote of naloxone, as well as the information, and peer spreads it to another peer. It's a little bit like the PPE here in the hospitals. All the nurses and a lot of people wearing the mask, not nurses, not to point out the nurses now, but maybe regular staff, they didn't realize how to wear the masks, So I heard from my cousin who's working in a hospital in Dublin, one of the things was like, you show someone, you're actually using it the wrong way there, and now you tell the next person you see who's wearing the mask wrong. And that's how they learned. And within a couple of days, the whole hospital knew. The new recruits who were volunteering, the new recruits knew now how to wear a mask. It's a very simple thing, but you can make a comparison between the harm reduction of COVID and the harm reduction of drugs. It's very similar.
And also one of the things we know is that peers tend to be very specific in what they teach people. So because if I'm using drugs alongside you, I will know what your drug use is. So if I know that you're a heroin smoker, I won't waste time talking to you about injecting. Whereas a professional outreach worker who meets you in the street is more likely to tell you everything they know, just on the off chance that they get the bits to stick. Whereas we tend to tell people much less, but stuff that is much more pertinent. And also we're then there in the moment of using. So actually that's that's when you've got the best chance to influence people. Now when I see someone lick their syringe, I'm like, oh man, what are you doing? You just put all the bacteria for your mouth on your needle and you're about to put it back in again. That person can choose to take the needle off, put a clean needle on and do something about that, rather than coming to me in a clinical room saying, God, look at this infection I've got because of this situation that happened. Or why do you think it even is? Because they may not even associate what was the situation that caused that problem. But just one other thing you highlighted as well, I don't want to make the drug scene sound completely benign. You might see I've got a bloodshot eye at the moment because I was robbed on a drug scene last weekend. And one of the things that's going on at the moment is also a degree of violence that's going around, a lot of peer-on-peer robbing, because people are really hard up. People can't beg. It's very hard to beg. It's very hard to do shoplifting. All the things that people at the bottom end of the system who might be surviving as day-to-day dependent drug users, that's quite challenging. And one of the other things drug users are doing in these open drug scenes is managing some quite volatile, difficult people. And I think one of the challenges that they have is that when people come and rob them, or when people come and break up their houses, they can't call the police, they can't seek assistance. So then they have to manage often some of the most violent, volatile people who are fluctuating around the drug scene with mental health issues, with alcohol problems, with underlying anger management issues or whatever else. The drug using community is left to manage on its own. And I think that is also something that I think can often underestimate some of the challenges that the drug using community is managing, alongside the good things that they're doing to help each other. We're helping each other with health issues.
And have you seen an uptake of drug courier deliveries during COVID? Is that a thing that might reduce the amount of human-to-human interaction for these types of situations?
Yeah, I mean, we've heard stories going around. I mean, I'm more operating and interacting in the harder drug scene, to use a more lazy term, people who have the harder human rights, harder criminalisation issues. We have heard people going out dressed as doctors, people signing up as Uber drivers, people turning up as mobile suppliers with full PPE. Yeah, I mean, there's any business is likely to adapt in light of COVID. So I don't think it's surprising that we'll see adaptations in the business as well. But of course, it's the part of the scene that is more affluent that can interact with those types of more costly models of sale. Now, those premium sales models that charge you more drugs to deliver to your home, you get better quality, all that sort of stuff. The problem is much more in the more street end of the market, and that's where things are much more volatile and much more challenging. And I think in the future, we do need to start thinking about, what do we offer people who are really living on the streets, living with challenges? We've got Big Issue and these homeless magazines, but what else can we offer people? Like, for example, the recharging of the electric scooters, the electric bikes. Some countries have got schemes for that to take place. I think we should start thinking about those types of things as being things that we can offer to the homeless and to people coming onto OST programs, so that there are things that people can do that aren't about shoplifting, aren't about causing harm to others, that allow them to struggle on and survive until they find their way into a more sustainable future.
Yeah, sustainable future is definitely the overarching question, as we have been kind of moving away from the use of hard currency. Like, say, this began in Europe specifically in Ireland, by banning, just removing 1 cent and 2 cent and 5 cents, so any of the copper coins. And this would have had an impact on people who would have been giving these copper coins to people that they'd see passing on the streets. There was actually an experiment ran in Oxford University in 2017, I believe, where they just gave Bitcoin wallets to all the homeless population in Oxford, and they were able to distribute Bitcoin directly to their mobile phone. So if you had a system like that, where you were giving a mobile phone with a Bitcoin wallet, The future is there's a rumor that PayPal and Venmo are going to integrate Bitcoin, and this could be a very simple way that you don't even have to be near someone to actually scan a QR code. You can scan a QR code like 50 meters away. As long as you have a Zoom on your phone, you can scan someone else. You have their wallet, you can just scan it. And I think it's going more and more away from paper cash. People don't want to touch it anymore, at least here anyway.
Yeah, look, I mean, I know there's a homeless woman who plays recorder in the streets in Bath. In fact, my mum and I both used to give her money, and I knew her from the drug scene as well. And my mum was on lockdown, and one of the challenges she had as everything went onto mobile, onto virtual systems, was that she couldn't keep her phone charged, and two, she couldn't keep credit on her phone. Now, in fact, she's one of the success stories of getting the homeless people off the street. But one of the ways that was possible was by, my mum generously being able to send money to put on a phone for her so that she could stay in touch with all the new services. Now, I think we've started to see these real acts of generosity between different people. And I think we need to start thinking of creative systems that allow the many good people in the general population who want to try and help people who are struggling to find their way forward, or just to survive to the next day sometimes.
Yeah, these are all examples of P2P systems, and upgrading your system from a centralized point, which can fail often, and allow other peers to connect to other peers. Like I remember being in San Francisco a number of years ago, maybe 2017, and a busker just had his QR code on the back of his banner, and you could just Venmo him money. I mean, it's very simple actually once you have these tools available to a society. Obviously, that's Silicon Valley. This is not Silicon Valley yet, but then Silicon Valley itself has been decentralized, because you don't need to be in San Francisco to create an app. You can be anywhere in the world, India, Nigeria, Libya, anywhere. So these are all examples.
And if you go to countries with like Russia and Ukraine, I mean, the creativity of drug suppliers and drug users in Ukraine, in those countries now, where there's such harsh criminalization. So now if you want to buy drugs there, you're connecting with people on social media. You're then transferring money through to a bank account by a transfer code. Once the supplier can see the transfer code, they then go and put the money in a location. They send you the GPS code. You go and pick up the GPS code, and you've brought drugs without even meeting the person. Now, then the person is then also able to get ratings and comments from other people, so you can then judge the quality of what they're selling and their service from the ratings that you're getting online. But I mean, I think the drug using community has always showed incredible creativity in using technology, and I think we really need to look at how we look after some of the most marginalised people, and they come with us in this technological revolution, not get left behind by it.
Absolutely, yeah, and maybe a way to have access to naloxone through these marketplaces and P2P, profiles, and have a naloxone advertisement up for people to not just order their heroin, but also get a free naloxone kit along with their heroin, and have the postman delivered for them. They don't have
we've already seen WhatsApp groups forming among local peer-to-peer networks, peer-to-peer naloxone networks. And I've heard stories like in Birmingham of drug users getting there before the ambulance when people called on the local WhatsApp network. I think we're looking at new technologies. Friends of mine are involved in trying to develop technology that could get people linked with naloxone, people carrying naloxone in a much more sophisticated way. The problem is I'm not sure Bluetooth is quite yet up to the standard of getting people close enough to people for it to work as yet. But I think these technologies are going to be life-saving. I mean, in the US now, there are people who will witness people having a hit because of the risk of fentanyl being contaminated with the heroin supply. So you can actually connect with someone online who will witness while you're having your injection, knowing what your address is, and then they can call the ambulance if you go over in front of them. Now, I think that some of this sort of compassionate caring for other people is quite remarkable, I think.
That's brilliant. Wow. I mean, yeah, there's a lot of people at home, doing nothing at the moment. If they were more empowered, if they understood this technology and be able to act as these kind of surveyors or watchtowers for other people in a private encrypted manner, they could easily be on standby watching these things while they have their own YouTube on or their own streams on, and just witness some of these interactions and better care for each other. I think that's a wonderful example you've brought up, and how we look at this as a stack. We see, you know, the access to drugs, the use of technology, the funding, all of these mechanisms have examples of P2P and the advantages towards that. I think this is a fascinating conversation, and one in which I hope we can catch up again at another call and run around some ideas, because I think this is definitely going in the right direction, Matt, and your work is really, really interesting. It's great. Yeah, thanks for sharing it with us.
Well, thank you very much for inviting me to come and speak to you. I've really enjoyed it.
It's been a pleasure.
Take care, Matt. Thanks a million.
Thanks again, Matt. Slán.